I'm tasked by reviewing, discussing the evolving assist devices, mechanical circulatory assist devices in cardiogenic shock. So let's start with some basic facts. First of all, do we need any assist devices in cardiogenic shock? I think everybody would agree that yes, we do. Despite significant advances, the mortality rate still remains in the range of 50%, depending on the trial, anywhere from 40 to 55%. The second point is, when we look at cardiogenic shock patients, it's a very heterogeneous cardiogenic shock patient. So the moment we say cardiogenic shock, we put 10 different types of patients in one group, which obviously doesn't make sense because the etiology may be different, heart failure or MI, the MI may be STEMI or non-STEMI, the mode of mortality may be cardiac arrest, and especially, as we will discuss, whether there is a hypoxic brain injury or not, that makes a huge difference. Regardless of the assist devices, even if we have the best assist device, one of the things which we encounter is the vascular complication of mechanical circulatory devices, unfortunately remains very high. This is an inpatient sample database, and if you look at the data, you see that there is a significant risk of vascular complication depending on the size of the device. In blue is the intra-aortic balloon pump, and in orange you'll see the Impella, and the highest rate of complications in the range of 15%, that's ECMO. So yes, we help patients by using a mechanical circulatory support, but we cause harm by vascular complications, bleeding, and ischemia. So what do we need to do to reverse the cardiogenic shock or prevent cardiogenic shock? So there are really 5 items that we need to keep in mind. The hallmark of the cardiogenic shock is the reduced cardiac output. That leads to decreased coronary perfusion. It leads to end organ perfusion and multi-organ dysfunction, and of course, multi-organ failure and death. So we need a system, we need a pathway to stop this spiral. These are some of them, this is a list of currently available mechanical circulatory devices. I've highlighted the ones that we use for left ventricular assist device because that's what we're going to concentrate on. And they include ECMO, balloon pump, Impella, and tandem heart. A quick review. Intra-aortic balloon pump, as was studied in the IAB shock trial, had no benefits in outcome. Fortunately, it had no risk either. So similar rate of vascular complication, and that's important. Sometimes we learn from negative trial. Even though it has no benefit, it had no risk. And why? We'll get back to that and likely relate to the size of the intra-aortic balloon pump. And the other thing to know that it included both STEMI and non-STEMI, and about 80% of the patient had the balloon pump inserted after the procedure. ECMO, we know that in the ECLS shock trial had no benefit, but also had significant risk, especially vascular complications. And the vascular complications was 3 times higher, and the bleeding was 2.5 times higher. So no benefit and risk. The only clinical trial which has shown benefit so far was the danger shock trial, which was a very highly selected patient population, a STEMI, no mechanical complication, no hypoxic brain injury, and both hypotension and hypoperfusion. And of course, remarkably, it showed a 13% reduction in the risk of mortality at 6 months. And that's huge. That's the first time we have shown reduction in the mortality rate of cardiogenic shock patient. 25 years ago, the shock trial was the first time that we saw revascularization showed benefit. So this is important. But unfortunately, it comes at the risk of, again, bleeding 2 times higher and limb ischemia 5 times higher, also renal replacement therapy, dialysis higher. So we need to replicate the benefits and try to minimize the risk that comes with this. So then it takes us to what are the risks and benefits of mechanical circulatory devices. Now the benefit, most of the time, it depends on the size of the device. The larger the device, the higher the cardiac output, so we get benefit. But unfortunately, the higher the size, the higher the risk of bleeding and organ damage and cell damage. So we need a device that has high cardiac output support, but does not have the vascular and bleeding risk associated with these devices. And hence, the new process or new facet of the cardiogenic shock and mechanical circulatory support are the new expandable devices. So devices that we can put, when we put them in, they are smaller, but they can grow to a larger profile. This is, is not an expansive list, but this is a list of some of these devices that I will quickly review. It includes Impella ECP device, expandable CP device. It includes the Supera platform system and the Magenta Medical Elevate mechanical circulatory support system. And these can achieve a cardiac output of 3 to 5 liters per minute at a smaller size, and that's important. This is an Impella ECP system. So similar to balloon pump, this is a 9 French inducer. Balloon pump, depending on the size, is 7 or 8 French. This is a 9 French system. But the pump is 21 French, so once it's unhatched in the aorta, it actually grows to become 21 French. On average, it gives a 2.7 to 3.8 liter flow, and for now, it's indicated for high-risk PCI, not cardiogenic shock, but hopefully it will be. This is how the device, it's unhatched. This is how the device, one of the difference between the current device and this device is, this is not an over-the-wire system because a smaller device, you actually have to advance the pigtail through the aortic valve without a wire, and the trick is you have to have a body wire or a pigtail to open the aortic valve while you insert it. But the early feasibility device, which was presented just recently at TCT, it showed, again, this was not a randomized trial, this was a prospective multi-center single-arm trial, and at least based on this smaller trial, which included 250 patients, the outcome was, the rate of event was in the range of 5 to 6%, expected to be about 9 to 10%. And more importantly, the vascular complication was very low, and the access site could be closed with an 8 French angiosyl. So benefit, but not the associated risk. The next device, again in this range, is a Supera system. This actually has both aortic and ventricular sensors, and that's important because it provides it can provide more hemodynamic benefit. This goes in as a 10 French and becomes 23 French in the system. So this is also an expandable circulatory system. The early feasibility data was presented at EuroPCR. Again, a small number of patients, proof of concept. Main thing is the benefit was there with regard to hemodynamic support, but fortunately, the vascular complications, only one patient in this small clinical trial had a safety endpoint or a vascular complication. And the last device is the Elevate Percutaneous LV Support System. This is a 10 French system. You can use any 10 French to put it. This is not a dedicated sheet. It goes in over the wire, 018 wire, and it goes as a 9 French through a 10 French sheet, and it becomes 30 French while in the system. So it is an expandable system, and it can deliver up to 5.4 liter of mean blood flow from the LV into the ascending aorta. This is how the device actually is a helical nitinol frame that it can be completely folded and a low profile. So the low profile allows it to get out of the 10 French sheet and then be retracted in the 10 French sheet when the procedure is done. This is an example of how the device is deployed. This is a similar device. I hope if somebody from Arjomand and Al-Nag is here, please close your eyes, because this is a similar deployment mechanism, the 018 wire in the ventricle. Again, a small feasibility, early feasibility study. As you see, the hemodynamically, it provides very good hemodynamics and map of more than 60 millimeter mercury in all cases. And first human trial included 15 patients. There were no hypotensive, no device-related adverse event, and they all did well without major vascular complication. So, and I probably need 30 seconds or 60 seconds. So what Here is the overview of all these three devices. Now, the Impella CP, as we know, is 14 French. Impella 505.5 is 23 French. Now, these devices grow bigger than the Impella CP, but they go through a 9 or 10 French system. So both Impella ECP, Supera, and Elevate system, they are lower profile. So how do we look at the cardiogenic shock going forward? As I said, it's a heterogeneous group of population. We need to look at patient selection, device, whether we're using a loading device or like ECMO, or unloading device like Impella, or one of these newer devices, hopefully. Are we using venting or unloading if we use a loading device? And what is the timing of this venting? And also revascularization. Is it culprit or not culprit? So as we stand, the clinical practice should be a STEMI patient, hypotension, hypoperfusion, no mechanical complication, no hypoxic brain injury, and what is approved currently, or what we know from the clinical trial, is the microaxial flow pump Impella CP. That's the only device that has shown significant benefit, and the likelihood is that this will change the clinical guidelines, hopefully, as a class 1, maybe class 1B going forward. What is the... oops. How about 2028, 2030? Let's look 3 to 5 years beyond. Hopefully, we should be able to do a high-risk PCI using a mechanical circulatory support, which is 8 to 10 French, so we get the benefit of improved cardiac output, but no associated vascular complication. I always like to finish with our Emirate Cardiogenic Shock Initiative. Professor Shahab and I were just discussing that. I'm actually working on the 4th draft. Hopefully, in early 2025, this will be published with recommendation, Emirate-wide, with regard to mechanical circulatory support in cardiogenic shock patients. Thank you very much.